Hello, everyone, and thank you for joining us today for this cancer conversation event. I'm Swan Paul Nobles. I'll be your moderator for this evening. I'm a member of the Omega Psi Phi Fraternity Incorporated and the Health Initiative Chair for the Ira New chapter. Today's conversation is part of a collaboration between members of Omega Psi Phi Fraternity Incorporated and the Mayo Clinic Community Outreach and Engagement Team. The series of conversations explores topics ranging from prostate cancer risk factors to survivorship. This session marks the second of four in this series. We invite you to join us for the upcoming sessions that will be held on June the 11th and June the 18th. We are grateful for the opportunity to bring this discussion to our communities. Before we get started, I'm going to go over some housekeeping tips. Everyone except speakers are in webinar mode, and so if you have any questions, please use the question and answer pane at the bottom of your screen. We invite you to share this webinar link with others that may want to join. There will also be a pre and post survey and other scanning opportunities during today's session. And for our speakers, we will be reminding you with general cues when your time is almost up. So now we're going to get started, and I'm going to turn over to Nicole Lander to lead the next session.
Thank you so much, Mr. Nobles. Good evening, everyone. My name is Nicole Landa. I'm a community engagement coordinator on our Mayo Clinic Florida team. I'm also our lead for all Hispanic initiatives that we have here as well. So tonight with our cancer conversation, this is our opportunity to be able to bring physicians, researchers, and the community together so that we're able to share and learn about various different types of cancers, their signs and symptoms, treatment, resources, as well as the benefits of participating in clinical trials. And in this event specifically, we're bringing in survivors and caregivers that will be able to share their unique health journeys. These conversations are designed to educate us on knowing our health risks and staying up to date on our screenings, which then empower us to take charge of our health. And if we could please go to the next slide, and we're just going to take a quick moment to look at our agenda. Wonderful. Oh, we're hearing an echo. Oh no. Let's see if this helps with the audio anymore. And then we can go ahead and move to the next slide. And so we're going to go into our pre-survey evaluation. So if we could all either scan the QR code with our cell phones, or we're also putting a survey in the link. If you can click on that, or link in the chat, if you can please click on that. And then it's a very quick survey. I'm going to give you a few minutes to complete that. And this is just a quick pre-test to test your knowledge today. And then we'll be completing another post-test at the year post-evaluation at the end of our presentation today. Okay, I think we're going to go ahead and start wrapping up. And if we could go to our next slide, and I'm going to pass it back to Mr. Swanpaul.
Thank you, Nicole. All right, our first speaker for the evening will be our medical expert, Dr. Ricky Ashby. Dr. Ricky Ashby is a Florida native who works on developing new treatments for cancer and rare genetic diseases. He went to the University of Florida for his education and started working as a physician at Mayo Clinic Internal Medicine residency program last year. He plans to go into hematology oncology fellowship after resident and plan to be a cancer doctor full time. And Dr. Rick Ashby, the floor is yours.
Thank you very much for the introduction. Yeah, so we can go to the next slide. And it's a pleasure to be here today. Thank you very much for your attention. Today, we're going to be talking about detection and diagnosis of prostate cancer. So there's going to be 4 major sections we're going to go into. First off is the primary screening tests we do, and we'll go into screening in a little bit and what that means, what symptoms to look for with prostate cancer, and diagnostic imaging that we would do after that first phase, and disease staging, which we'll get into in a little bit. And next, please. All right, so screening, when doctors talk about screening, what we really mean is we're looking to diagnose a specific disease before it shows any symptoms or causes any problems for that person. That's one of the major differences, diagnosis and screening are not mutually exclusive, but they are technically referring to 2 different things. So when we talk about screening, it's specifically before it has symptoms. And next slide. We have a little question. So I know that you guys can't talk in the chat, and you guys can just answer on your own if you'd like, just to yourselves. So, but essentially, just to get engaged a little bit and kind of think about it, what do you think the main method would be for screening for prostate cancer in the United States? Do you think it would be a CAT scan, like imaging, physical exam, which has a lot of rumors about screening for prostate cancer in the United States, prostate-specific antigen, which is a blood test, and or is it symptoms? Do we screen based on just asking the patient about their history? So and we don't have to take too much time, but if you guys have an idea, thank you everyone who has presented any sort of answer. So many people don't realize it's actually C. So all we really have is a blood test. We can go next. And essentially this prostate-specific antigen, we can just go forward on the slides, and it's essentially we have prostate-specific antigen, which is just a simple blood test. You get this with your annual physicals and everything. So this will tell us essentially an idea as to if we need to look farther for prostate cancer in someone. So this will show up as a test that we can use for cancer long before someone has symptoms. So the problem with using something like PSA is that it can be triggered by a lot of different things. So a lot of things can throw off the test. It's not perfect. This can include inflammation. If you're having difficulty going to the bathroom, any medications you're taking, some of them can actually increase your PSA levels, which is a blood test. Many of you may have had it before. And even exercise and bicycle riding can actually increase it. Some medications can even lower your BPH, your BSA, and having certain diseases as well, like enlarged prostate or BPH, that can also increase your PSA. So that's why it's important. You can't just get a PSA just in isolation. You need to have multiple PSAs over a course of time. That's why following up with your primary care physician is really important. A lot of what we use is really just what we call velocity, which is the change over time of PSA, the number that you get from it. And we can monitor it over the course of years. We can monitor it over the course of months, and your doctor can kind of time it based on your specific risk factors. And next slide, please. The U.S. Preventative Services Task Force, which is the head authority on when we should start screening for things, says that it's recommended to start discussing the risks and benefits of prostate cancer screening, in this case, PSA testing, ages 55 and up. And that's recommended to do it less after age 70, mostly because the life expectancy at age 70 is a lot lower. So the benefits of treatment might not be as great at that point. But the American Cancer Society, who obviously specializes in cancer, has a bit of a different take. They recommend starting at age 50 and continue screening for anybody who has a life expectancy of at least 10 years. Because reasonably speaking, a lot of people are living longer. So if you're a 70-year-old and you're really healthy, you're fit, you're active and everything, it does make sense to actually keep continuing the screening, because if you do catch prostate cancer early, you might be able to treat it and live a lot more years. And of course, you can start at age 45 or even as early as 40 if you have certain risk factors as well. And that's important to really have a conversation with your doctor about what those risk factors look like. And next, please. So some of you may be wondering, what symptoms should I look out for? Maybe I don't want to screen. Maybe I just want to know what my symptoms would be. So which of these options do you think might be essentially the main way that people show up to their doctor and get diagnosed with prostate cancer? Yeah, and thank you to everyone who's given some kind of an answer, whether it's to yourself or whether it's in the chat. I think it's great to open these discussions because it's actually D. Go on to the next one. Prostate cancer tends to not have symptoms usually, and that's why screening is so critically important. That's why the PSA is, still recommended for people after they reach a certain age. About 3/4 of people who are diagnosed with prostate cancer are diagnosed simply from the screening test alone. And because of the lack of symptoms, that really limits our ability to treat them early if they're not getting screened. So there's different stages of prostate cancer we'll get into a little later, but early stage versus late stage for symptoms are going to look very different. Probably less than 5% of patients who actually have early stage will actually have any symptoms whatsoever. But it can sometimes present itself in rare occasion with urinary issues, so difficulty going to the bathroom or blood in your urine. And next slide, and a little bit of erectile dysfunction, things like that. So going to your doctor and getting screening is really the best way to really try and catch early stage prostate cancer, which is when a lot of the treatment is really available. This is important to consider. We talk about risks versus benefits with screening. The benefits generally outweigh the risks when you screen for prostate cancer, but there are risks because you might treat a cancer that might not have caused you any issues. And that's been kind of shown with some autopsy reports that came out many years ago of men who were age 50 to 59 who passed away from other reasons. 20% of them, 1 in 5, had prostate cancer of some kind. At age 70, 1 in 3 had prostate cancer. And these were people who died from, heart attack, stroke, and other things. And it was completely unrelated to the cancer. So a little bit of food for thought. This has led to some discussions and debates about, are we overdiagnosing? Are we overtreating prostate cancer? But generally speaking, as long as you have a good relationship with your physician and everything, we usually would recommend screening just because it's better to know. However, it's totally reasonable to elect not to, as long as you understand the risks associated with that. And that being said, if you are getting screened, you don't necessarily have to treat it too. And we can get into what that might look like, that discussion with getting screening regularly and finding a cancer and intentionally choosing not to treat it and when that would be appropriate. So next slide. And we're still in the symptom section. So late stage prostate cancer is typically when you'd have symptoms, when it's really, really late. And actually most cases of late stage prostate cancer actually still don't have many symptoms at all. However, those that do have symptoms, they typically show up as things like fever and weight loss. And we can just click next just to make those show up. Some bone pain and some bone fractures. And the reason for that is we can have metastases to the bones as well as different areas of the body. But the prostate cancer really prefers the bones quite a bit, particularly in the bones that are kind of around the prostate area. So it goes to the back. So a lot of people actually have vertebral metastases, and that's where you get a lot of the fractures, the vertebral fractures, which can be quite painful. You can also less commonly have some more distant metastases that can cause some rare side effects, but that's typically with much more advanced metastatic cancer. And next section. So diagnostic imaging. Let's say hypothetically that you have someone, and let's go back for a second. And let's say we have someone who comes in, they have elevated PSA. The next thing we want to do is we want to confirm if it's cancer. That's step one. And next slide. So how would we do that? Well, these days, thankfully, we've done a lot of clinical trials that we know the answer is usually to get an MRI of the prostate. So that is sometimes referred to as a multi-parametric MRI. That's just the technical way that they do it for prostates. And this is based on the PROMISE trial, which compared doing a biopsy to doing an MRI. An MRI is actually so accurate that we prefer to do the MRI first now because it's more accurate than some biopsies even. So we would do the MRI first, and if it's negative, we can rest assured that it's negative, so you can skip doing a biopsy. And when I say biopsy, that means you take a needle, you take a sample of the cancer, which can obviously be very invasive. So it's good that we're able to actually prevent that now. So there's a lot more strategies that weren't available even just 10 years ago. And there's a little workflow down at the bottom, so we can just advance that a little bit. So the typical workflow would be someone comes into the clinic, they have an increasing PSA level. What we want to do is we want to repeat that to make sure it's still increasing and it's actually real. Because I mentioned there's a lot of things that can throw off the test, even just exercise, or maybe you just had bad cold that day. And if it's still increasing and your doctor thinks it's concerning enough that we would need to do more advanced imaging, then we would do the MRI first usually. And if that MRI is positive, we would do a biopsy. It used to be we just go straight to biopsy, but these days this MRI has helped us to avoid some biopsies. And next. So ultrasound is sometimes done, that can be done through a number of different anatomic approaches. And you can do less invasive anatomic approaches if the tumor is on the anterior side of your prostate, basically the front of your prostate, but only if it's there. The ultrasound itself is not actually helpful in diagnosing the prostate cancer. However, it is used to guide the biopsy, which is that needle that takes a sample of the cancer to essentially look at it under the microscope. So the other advantage to doing the MRI first is nowadays we have software that can send information from the MRI to the ultrasound to make it more precise. So there's less tissue damage, it's less painful, etc. And this lets us, take a look at what the tumor actually looks like under the microscope. And next, that gets into disease staging. So step one was figure out, is it cancer? Step two is to determine if it spread, and if it did spread, how far did it spread? And next slide. So one of the scores that we use to kind of see how bad is the cancer is what we call Gleason score. So anyone who's been through the process of diagnosing prostate cancer is probably familiar with a Gleason score. So it's from 2 to 10, the score, and that gives us our grade. And I only go over it just to so you have some ideas to how this works. So up at the top on the right is what prostate tissue looks like under the microscope. On the top is normal prostate tissue, and as you go down, it gets worse and worse, and the grade gets worse. So essentially, if you have a higher grade, you have a higher risk of it spreading to other parts of the body. And there's very limited clinical correlation. And what we mean by that is, it's not a perfect measure. So just because you have a high Gleason score in and of itself isn't always necessarily that bad. But we do know that if the Gleason score is less than 6, that's associated with much better outcomes. So it's a really good news if your Gleason score is less than 6 in this case. And next slide. And this is just how we use this information. So we get lots of information by this point, right? We have already done the MRI, we've done the biopsy, we've taken a look at what it looks like under the microscope and given it a grade. And if it's a low risk, meaning it's a small tumor, the histology grade is very low, so it looks very normal. And the PSA is also not that high, it's less than 10. We would actually recommend, based on the NCCN guidelines, just continuing surveillance. So just monitoring it, repeat it in 6 months, just check it next year or something like that if you're comfortable with it. And we would not recommend actually pursuing aggressive treatment in most of these cases. And so that's an example of why screening could still be a benefit, even if you're a bit hesitant of considering therapies for cancer. It's sometimes just good to know it's there. But for some people, they might just prefer not to know. And it would be important to talk with your doctor about what the risks of that would look like if you choose not to screen. And the intermediate risk at this stage would be if it's, grade 2 or 3. So that's a little bit higher, going down that chart a little bit more. If the PSA is, 10 to 20, or if the tumor is just a little bigger, then it's kind of a toss-up. There's not really good evidence one way or another. So then you'd have to have your doctor kind of look into you individually and see what they think. Do you have a lot of risk factors for prostate cancer that are more concerning? Are there any other results from the biopsy that might steer the doctor one way or another? And that would be a tough decision generally between you and your oncologist at that point. High risk groups, that's usually pretty, if you have a large tumor, the grade is 4 to 5. I said there's not really much of a clinical correlation, but still, we don't want to take that risk. If it's a high grade, we would generally want to, take it out before it spreads, just so that it doesn't put you at risk. And if the PSA is really, really high, that's another thing that would kind of indicate for us to want to scan the rest of the body and see what's there, and then give you good advice based on that. And next. So advanced imaging, which is scanning the whole body, because remember the first step was figuring out, okay, we have all this lab data, we have this MRI data, is it really cancer? The biopsy told us it is cancer. So at this point, and we, if it is cancer, then the other question is, do we want to actually treat it, or do you want to just watch it? Because there's a lot of slow growing prostate cancers out there. At this point, we're saying we kind of are leaning towards, we want to know our options for treatment. We're worried it might have spread. And typically we do this by just doing a CT scan of the chest, abdomen, and pelvis, and doing a bone scan, which we don't really usually do anymore. That's largely been replaced at this point by PET scans. PSMA PET scan specifically for prostate is the gold standard now. Some centers actually do a PET scan, which is just essentially where you take a little radioactive antibody, and that gets injected into you. That antibody will only hit prostate cancer, essentially, or tissue that expresses this protein, which is usually only expressed on prostate cancer, if you will. And so there's CT or MRI versions of this. Essentially, different centers will prefer it one way or another. MRI is usually better because it shows soft tissue a little better, but both of them work quite well. It'll just vary depending on which academic center you're working at and availability of the MRI, which is very specialized. And next. So last is genetic testing. So one thing that you might want to do after you're diagnosed with prostate cancer is consider what your doctor calls germline genetic testing. So that is where we're testing your DNA, not the cancer's DNA, but your DNA, to see if there are any inherited mutations that you might have or any genetic diseases that you might have. So why would you want to do that? Well, it might change, how you screen for other cancers that are not prostate cancers, because there are some diseases where it increases your risk for a lot of different cancers. It also might have implications for your children or your brothers or any of your relatives who are closely related to you. And, if you test positive for this, they might want to get tested too. And if they test positive, they might want to start their screening earlier, whether for prostate cancer or whether for other cancers, depending on what the mutation is. And so for genetic testing of the tumor itself, that's for germline. There's also genetic testing we can do of the actual tumor. So we took a biopsy, right? So we took a needle, took a sample of that cancer. We were able to tell it's cancer and all that. We can also do genetic tests on it and actually see what that cancer is made of. What did it do differently? How did it mutate differently from your DNA. And with that, they can actually see if you're eligible for what we call targeted therapy, because there are some mutations that can actually be targeted with specific drugs these days. And it's kind of like winning the lottery sometimes. If you get a really good target, like a drug that works really well, and you don't know until you screen for it. So at Mayo, we typically just do that for almost any cancer that gets diagnosed, usually, just because why not? So that's another thing that might come up during the diagnostic process. Lastly, there's this thing called a liquid biopsy. You'll hear that as a common word. It's not really the best term for it, but essentially, it's just taking a sample of your blood and looking for if there's cancer DNA in your blood, because cancer is very unstable. It'll break apart and the DNA will leak everywhere. And it's very small amounts of it, but it's enough to where we can actually detect it with some lab tests. So that liquid biopsy will help us in cases where we've treated you and the cancer is on imaging completely gone, but there still might be microscopic cancer hiding somewhere. And so that liquid biopsy lets us kind of monitor it and see, is the cancer DNA in your blood starting to go up before we can see anything on imaging. And that might help us when we're deciding on what to do, treatment, etc. And I think I'm over by a little bit. So with that, that's about it. I thank you so much for your time, and I'm happy to take any questions. And if we're not able to get to your question during the Q&A session, that's my email right there. I'm happy to answer anything you guys have, questions, concerns, otherwise. And I'll pass it over to whoever's next.
Thank you, Dr. Ricky Ashby, for your useful and beneficial information over prostate cancer. Can we go to the next slide? Do we have time for anyone have free questions for Dr. Ricky Ashby? Before we go into our next speaker. All right, the next speaker would be our survivor, which is my chapter brother, Mr. Steve Briggs. Steve Briggs is a God-fearing family man, U.S. Navy veteran, prostate cancer survivor whose journey is rooted in faith, resilience, and service to others. He was diagnosed in 2016 after recognizing early warning signs and seeking medical evaluation. Steve chose radiation therapy as his treatment path, allowing him to maintain his quality of life throughout the process. Nearly 9 years later, he remained in remission and continued to use his experience to uplift and educate others. Today, he mentors his men facing similar diagnoses, advocating for early screening, awareness, and informed decision-making. Ladies and gentlemen, now I introduce Mr. Steve Briggs. Steve, you have the floor.
Thank you, my brother. And thank you, Mayo, for doing this today. It was quite scary for us back in 2016. My wife and I went to the doctor. I started noticing that I was urinating a lot in the middle of the night on trips to football games, college football games, and urinating a lot. And so we went to the doctor. They did the old-fashioned test, which you all guys know what that is. And he thought everything was fine. The doctor said, "Well, I think you're okay." Went back a month later and said, "No, doctor, we have to do something else because that I just know there's something wrong." And you have to be persistent sometimes when you know there's just something wrong, but it's not indicated right away. So I insisted another test, and they gave me the PSA test, and it had an elevated PSA level. So he said, "Wait a couple of months and come on back, and we'll test you again." Well, I waited a couple of months and went back, and yes, it was higher than it was previously. So we decided that, yeah, you might have prostate cancer. So they did a biopsy. We did a biopsy. One of the worst things I ever gone through, but necessary to survive. So we did a biopsy, and it came back. I had several. Well, no, we did the PSA test, and it came back that I had prostate cancer. It was higher. We did a biopsy, and I had several uh, spots that were out there that needed to be addressed. So I just went to the doctors, decided first, hey, let's go ahead and do surgery. Let's just remove the prostate and be done with it. So I did a little research, and it's good to do research and ask all the questions that you want to ask. And I said, what are the side effects? thought the side effects was a bit much for a guy my age. I think at that time I was around 50, 54, from around that age. So I said, what are my options? And they told me about radiation treatment and how radiation just pinpoints the prostate, and it's kind of saves the other organs around the prostate, as i.e. your rectum and other organs. So we found a good doctor. We went and had 13 treatments of a week for prostate uh, t- radiation treatment. And after I was done with my 13 weeks, we went back about a month later and did a PSA, and my PSA dropped tremendously. And it was a good feeling. Of course, we prayed about it, and I thought about it. People that go without even getting diagnosed or just ignore symptoms. You know, the prostate might not kill you. I have a brother that was younger than me, and he had prostate cancer right after I did, and he ignored all the symptoms, and he passed away. And what happened was it spread. It spread from from his prostate to other organs, liver, rectum, colon. It just spread, and he passed away. Not saying that if he had it would have made a difference. I believe it would have made a difference if they could have just kept it in the prostate area, and but instead he didn't go to the doctor. He didn't follow up. And by the time he did go to the doctor, it had spread. I think they call it metastasized, and he passed away. So from the rest of my life, I decided to be a spokesperson to teach and reach each and every man, white, black, it doesn't matter. But it really affects the African American community a little more so than the other communities so far of what I've seen. And so anytime I come across a brother or a person that is experiencing the symptoms that I experienced, I say, hey, let's go get this checked out. Let's go talk to somebody. I don't care, who you go see, but go see a doctor. And these are the tests. And then I talked about some of the things that helped me because my doctor was really surprised how well I did during the radiation treatment, how well I did recovery. Um, and then I recovered completely. Didn't need any additional medications, i.e. ED medicine, didn't need any of that. And I just felt like it was first it was God, then it was the professionals of the doctors and the staff that I received and the information that I received, and then the support from your family is very, very important. And my wife will make me special berry drinks because according to research, berries is a good fruit to eat to stop prostate cancer or to hold it back or fight it off. So a lot of berry juices, fruit juices, strawberries, raspberries, any kind of berry you definitely want to use that as well. And I dedicated the rest of my life on reaching um, guys anywhere from 45 to 70 in prostate. And now I worked with the Beam team at Dr. Ackerman's office. And when somebody comes in for their first treatment, I'm normally there for them. I talk to them and tell them what they can expect to go through and what's expected. If you have any problems, I'll be a liaison between the doctors, staff, and the individual that they assign me. And I just appreciate what Mayo is doing right now, just taking the time, each and every one of you guys here as a monitor, as a host, to take the time to teach this because really education costs. That could cost you your life if you don't get it. So I'm glad that people are taking prostate serious. I'm glad my brother took this, brother Nobles took this on, and I'm so proud of the way he's done this, and I hope that the rest of the information gets out to anybody that missed it, that we continue to keep open communication up and make prostate cancer a survivable cancer, in which it is a survivable cancer. Anytime you hear the word cancer, you automatically get nervous. I went through I went through the prostate exam. I went through the test. I went through the PSA test before I even mentioned it to my wife and my two boys. I didn't want them to be worried about something that I didn't think was so serious. But once they said, yes, you're positive for cancer, that's when I included the family on what was going on. And then just the first reactions of all three of them were different. The reaction of my wife was of course panicking. Oh my God, we have 30 at that time we had 30 years of marriage, and now it's 42, thank God. she was just, oh no, I'm gonna lose you, I'm gonna lose you, cancer. But my son, the one in the Navy, commander, he said, okay, Dad, we're gonna research this thing, we're gonna beat it, we're gonna all get together. You go, and he started directing people, go do this, you do this, research this, get this. And then my youngest son, my youngest son took it to rough. He was in college at the time, and he passed out. He couldn't believe it because his buddy had lost his father the year before that. So he thought he was going to lose me too, and he passed out right there. Uh, and so it's different. So if I can tell you anything, do your homework, read, talk to people that have gone through what you go through, because it's easier when they know what's going to happen, what to expect. And pretty much the same thing happens during prostate cancer. Research the treatment is pretty much the same. Radiation treatment is pretty much the same. You can expect this, you can expect that. And when they know it, they come back to it. They say, hey, Steve Briggs, man, you were right, man. That's exactly what happened. I appreciate you. And just to be there and support each and every one of us, each one teach one. And then that's what we do. And I thank you guys very much for asking me to participate this in this educational forum concerning prostate cancer. And you might have saved a life today. You might have saved a life. Thank you. And that is all. Any questions? Okay, there are no questions. So thank you very much, guys. Appreciate it.
All right, thank you, Brother Briggs, for answering the call and sharing your story with us today. Like you say, hopefully we save a life today.
Yes.
And there's no any questions. I'd like to turn it over to Nicole to lead the next session.
Of course. Thank you so much. Oh, let me have my video. And of course, if you have any questions that pop up, please feel free to use the chat or the question and answer. I saw Dr. Ashby answering some questions already, and we can always get back to them too. I know sometimes it takes some time to think through those questions as well, especially when we receive such powerful stories and testimonials that were shared. And so, Chad, if we can go ahead and share the screen, and then we'll go ahead and complete our post eval very quickly. And then we'll also have the link in the chat too, if that's easier for you to use. And then I'll just give us a few minutes to complete this, and then we'll move on with our agenda. Okay, so we're going to go ahead and move on through our post survey. I'm actually going to bring Dr. Ashby back to the floor. Saw that we had some questions come through and he was answering them. But I just wanted you to go over some of those responses too to see if that prompts any other questions.
Hey, thank you. Yeah, so I had a couple questions that showed up to me. There might be more. Let me see. I don't see any in the general chat, but for the Q&A section, I thought there were some great things to bring up. So there was a gentleman who brought up a question about a common issue that many men have over the age of 50 or sometimes as early as 40. So they got a sonogram at the EVA of their prostate, I'm presuming it's implied, because he was having what the medical term for this is nocturia. It's very common, where you actually get woken up in the middle of the night because you have to go to the bathroom really bad. So what's happening there usually is that the prostate is enlarging all over, and it compresses the urethra, which we pee with. So essentially, that makes it so that you get your bladder gets over full, and you're frequently having to go to the bathroom because it's getting to the point where the pressure's just built up so much. So it's like an overflow situation. But anyways, getting into what he's asking. They gave him a pill, which the common pills that we give are tamsulosin or finasteride. You don't have to worry about those specific medications. But essentially, there's pills that we give for it to hopefully shrink the prostate and make that obstruction go away, and that makes the nighttime peeing go away. Unfortunately, I see a lot of men in clinic where the first line doesn't work, and they frequently have to up the dose, or they have to add on other medications because there's two different medication mechanisms. There's one that's a alpha blocker, the other is a testosterone inhibitor. You don't have to worry about that, but basically just know that there's two different types of pills we can give, and we can go up on the dose. We can add on different ones, but we often get asked, does this increase my risk for prostate cancer? And you'll see why. It's better to get screening because you're very lucky if you came in and you got diagnosed based on urinary symptoms, like the wonderful speaker did. It's good to be aware of this, and it's good to go see a doctor if you're having those urinary issues, because it could be a number of things. It could just be BPH, which is enlarged prostate, as it was likely the case here. But it could also be prostate cancer on a more severe situation. So there's this ambiguity here, and we frequently get a lot of questions in clinic. Well, I have one large prostate. Am I at higher risk of prostate cancer? And technically speaking, not really. They kind of happen for different reasons. So if you have BPH, if you have an enlarged prostate, you should still get regular prostate cancer screening. So get that PSA every year and talk with your doctor about it too. If you're concerned with your doctor about, the fact that your urinary symptoms haven't gone away, you want more tests, it's a totally valid thing to, have a doctor's visit about. So definitely talk to them about it, and they'll be able to talk through your symptoms and work on a plan for you and go from there. And the other question, oh yeah,
I saw one question in the chat. I'm not sure if you got a chance to see it yet.
I might have missed it.
Yes, no problem. So Mr. York was asking if they have prostate surgery, is the doctor able to remove only part of the prostate, or does all of it have to be removed?
Yeah, so that's a great question. I definitely would say that's extremely case by case dependent. Usually they remove the entire thing, just be sure, just because there might be microscopic amounts of the prostate cancer, the part that's actually cancerous, that we just don't see. So usually speaking, they would take the whole thing out. In principle, yes, you could only take out part of it. And sometimes I understand that does happen. I think the surgeons would probably do a better job at explaining what the nuances would be for when you do one or the other. But essentially, it has to do with how big it is, long story short, and where it is also location wise. So the prostate is actually, two different, hemispheres. You have a left and a right and everything. So if there's overlap between them, then definitely you'd want to usually take the whole thing out. Hope that kind of answered your question. And then we had another great question that was about the age minimum for starting the tests without having symptoms. And that's what we call screening and everything. And I went over that a little bit, but I apologize I had to fly through, and I can provide those slides for you guys if you guys need anything. And this is all really just taken from the USPS, U.S. Preventative Services Task Force website. And it's also from the American Cancer Society website. I usually use the American Cancer Society screening methods. I think that they just have a better explanation for it, and it's more nuanced too. I might be biased because I want to go into cancer, right? But USPS is they still have. I mean, there's no right or wrong answer because in the case of USPS, they're also operating by taking into account the fact that the prior methods we used to use to diagnose prostate cancer led to a lot of people getting treated who likely would have just had a disease that might not have caused issues to them personally. But that being said, we've gotten a lot better at the techniques we use now. Like I mentioned, the MRI that wasn't even available, even just going back 10 years ago or so. And that's able to prevent you from even needing to get a biopsy for most cases. So the idea is we're getting better at, figuring out who needs to get the more invasive tests, who needs the more invasive treatment. And we just didn't have that infrastructure before. USPS, U.S. Preventative Services Task Force, they're kind of operating on a lot of older data, and ACS, American Cancer Society, is operating on more what we have today. So to answer the question about, specifically when we should start screening, it's really going to depend on the person because not everyone's the same. So if you are completely healthy, no risk factors for prostate cancer at all, which I believe have been covered by a previous lecture and everything, then, starting at 50 is what I usually recommend for most of my patients in clinic. If you have some risk factors or you're concerned about it, let's say, your father passed away from prostate cancer. They got it when they were, let's say, 60, which is pretty young for prostate cancer. Not super young, but young enough to where they're concerned. You can reasonably start at 45 because that's a risk factor. If you have a lot of risk factors, let's say you're smoking, you have multiple relatives, a father and a brother who had prostate cancer and they were pretty young when they got it, then you can start at 40, is what the American Cancer Society would recommend. Sure, you could start screening younger than that, but I don't think any insurance is going to cover that. But in some cases, if you have a proven genetic disorder that increases your risk for prostate cancer by a lot, there's a lot of different genetic disorders that can do that. Not to get into the specifics of it, but let's say that was the case. I mean, you could reasonably start screening even in your 30s. That's very rare, though. Hope that thoroughly answered your question.
Thank you so much, Dr. Ashby. I really appreciate your answers. And I know that we have some thank yous in the chat as well for your time today. So thank you so much. Chad, if you wouldn't mind pulling up the slides, and then I'm going to just start closing us out with some of our last few items for tonight. So I have some calls to action, how to get involved with Mayo Clinic tonight. So some of our opportunities that we have here are our community engagement studios. So this is an opportunity we have to be able to be involved with our researchers at Mayo Clinic. So essentially, our researchers are wanting to know the best way to implement their research in community, and who better than our community members to be able to provide that honest feedback. And so with the community engagement studio, you can scan this QR code here, or the link is now in the chat. And it's just going to, when you go to this link, ask you what topics you're interested in, as well as your contact information, so we can get back to you whenever we have a researcher that's requesting for some community feedback. And then essentially we put together a meeting, usually, simple or similar to this. We have a Zoom meeting for about an hour and a half. They're usually Zoom, but sometimes we have in person as well. And then our researcher will present their questions, give a brief overview of their study, and have just a few questions where you get to share your honest feedback There's no right or wrong answers. And then another opportunity, oh, and then you also will be paid for your time afterwards, after you complete one of our community engagement studios as a thank you. And then for our community research registry, if you click this or use this QR code as well as the link in the chat, this will take you to another survey that's going to help us create a profile for you so that you learn of all the different research opportunities that we have at Mayo Clinic. So this is a way to be empowered and learn of the different research opportunities that we have available to us. I feel like a lot of times this isn't, a resource that we know of, and we don't know what different types of research is out there for us. So this survey will let you know different types. It can be as simple as a survey that you're completing to provide feedback for our researchers, or a focus group to provide feedback, or it could also be something like a clinical trial study of a certain condition that you might be interested in receiving care for. So you get to let us know what you're interested in. That creates a profile for you, and then we will match you and let you know if there's any available studies that match your requirements. And so it's not signing you up for anything, but it's just sending you those available opportunities if you are interested. So then you can take that next step to reach out if you would like to. And then on the next or a few other ways that you can stay involved with us is if you are a survivor or caregiver, we would love to have you involved in an opportunity just like this, our cancer conversation, where you can share your story, your testimonial with our community members and really change lives. Another opportunity is our community scientist program, very similar to the idea of what our community engagement studio is, except you will be matched with a science or a research team at Mayo Clinic and really be part of that team and being that feedback for them, that community expert for them. And then lastly, we have our cancer advocacy training. So we'll actually be kicking it off this summer, and we'll have those dates for you very soon. But we will have a cancer advocacy training that essentially trains our community members to become advocates for our cancer prevention in the community. They also become essentially an extension of our team members, and they're able to help us and attend events with us and be able to provide education and programs for our community. And then tab the next slide, please. And then next we have our social media. So that's another great way to stay involved with us. We have our Instagram at Mayo Clinic Core, and then our Facebook. That's a great way to see the different events we have, not just here in Florida, but in our other two sites in Arizona and Minnesota, and really see the impact that we're doing in the community, get some ideas of some other work that we're doing with other partners, and maybe think of ways to work with us in the future. And then we also have our community newsletter that we have a shortened link for you there to be able to register for our newsletter and see all of the work that we're doing in the community as well. And the next slide, please. And so here we have some upcoming events. The Omega Sci-Fi SciMu New Chapter will be having their 2026 Men's Virtual Health Fair on June 13th. So that's a Saturday from 10 a.m. to 12 p.m. It will be a virtual event. They'll be talking about managing and preventing hypertension, diabetes awareness and lifestyle changes, as well as prostate cancer early detection and care. And so I also want to make sure we remember to register for our next few prostate cancer conversation of this series. So today we have completed our detection and diagnosis, or we're about to complete it. And then we have our June 11th treatment and June 18th survivorship and prevention. And make sure you sign up for each one individually. Unfortunately, you aren't able to sign up for all of them at once. So you'll have to revisit that link whenever you get to it. And then next slide, please. Thank you so much. And we can go ahead and bring up our next speaker. So we have Miss Jessica Hogue is going to talk about this prostate cancer research study opportunity.
Hi, everybody. My name is Jessica, and I'm a clinical research coordinator at Mayo, and I am working on the vitamin D prostate cancer study that we have with some of our physicians here at Mayo. So I just wanted to say thank you for having me and to kind of give an overview of what the study is about in case you or someone you know might be interested in participating. The goal of the study is to evaluate how common vitamin D deficiency is among African American prostate cancer patients, as well as analyze how vitamin D deficiency affects the immune system. So what we're doing is we are giving patients 8 weeks of a vitamin D pill. The amount is 2,000 international units or 50 micrograms, and that's daily. There are 3 blood draws that are involved, and the reasons for those are to get your calcium and vitamin D levels before and after, as well as getting the immunology information for the researchers on the study. There's also 2 physician visits, and then we follow your chart for 3 years to see your PSA levels and if there are any changes in your prostate cancer status. You get $75 for participating, and it does not cost you anything to participate. The study covers the vitamin D and the visits with the providers and everything like that. And you actually don't have to be near a Mayo Clinic, which is very special about this study, is that you can be anywhere in the US because we have local groups that are working with us on the study. So we are specifically looking for African American males who have a history of prostate cancer, who are not currently taking vitamin D over 400 international units or 10 micrograms. And so in the chat, we are putting my contact information as well as a flyer and a Mayo link with general information about the study and a screening survey. So if you think you might be interested in signing up for the study or just learning more about the study, if you know someone who might be interested in it, then you can feel free to reach out to me, or you can start the screening survey to see if that person would qualify. So that's a little bit about the study. It's a really cool study with vitamin D. So if anyone has any questions, please reach out. I'm very happy to be here. Thank you.
Thank you so much, Jessica. I really appreciate you for being here tonight and sharing that study highlight for us. And then as mentioned, her information is in the chat, so feel free to reach out with any questions. And then can we go to our next slide? And I'm going to go ahead and turn it over to Mr. Nobles to close this out for tonight, as well as give his study announcements and social media.
Thank you, Nicole. Yeah, to reach out to my chapter, our autoimmune new chapter of Omega Psi Phi Fraternity Incorporated, you just go on LinkedIn. I mean, not LinkedIn. Social media, you can go to Instagram, Facebook, Quad County Cubes. All right, next slide. All right, everyone, thank you for enjoying us today. So we're going to go ahead and do a closeout. But first of all, I want to thank all the speakers for sharing your time, insight, and experience with us today. Finally, thank you for the audience for joining us and being part of this important conversation. I also like to extend our sincere appreciation to the Mayo Clinic staff for their assistance in coordinating this event. A recording of today's program we made available to everyone who registered. Please encourage you to share the information and resource you learned today with others who may benefit from them. This concludes today's Cancer Conversation, and thank you again for joining us. Thank you.